Hello, everyone, and welcome to today's webinar, Time for a New Path Toward Healing, Advancing Active Wound Bed Preparation. Before we get started, I'd like to go over a few items so you know how to participate in today's virtual event. We've taken a screenshot here of an example of the attendee interface, and you should see something that looks like this on your own computer desktop. You've joined audio listening through your computer speaker system by default, and if for any reason you'd like to change that to telephone, just select phone call in the audio section of your control panel and the dial-in information will be displayed. And you can submit questions to our presenters today by typing them into the questions box of your control panel. You can submit those questions at any time and we'll be addressing them during the Q&A portion at the end. There are a couple of resources available for download in the handout section of your control panel. To save them, you'll just click on each title. They will open up in a separate window, and then from there you can print them or you can save them to your computer. I would now like to introduce Karen Laforet. She is an accomplished nurse leader with over 30 years of healthcare experience in critical care, community care, industry, and academia. She has a master's in clinical science, wound healing from Western University, and is recognized globally as an expert in infusion therapy and skin and wound care management. And our second speaker is Kimberly LeBlanc. She is the academic chair of the Wound Ostomy Continence Institute and a certified wound ostomy and continence nurse working with KDS Professional Consulting. She is an adjunct professor with the University of Western Ontario Masters in Wound Care Program and a visiting lecturer at the McGill University School of Nursing and University of Ottawa. Both our presenters lecture nationally and internationally, and we are so delighted that they have joined us in today's webinar. So welcome, Kim and Karen. And Kim, over to you.
Thank you so much for that great introduction, and thank you to all of you for joining us this evening. I don't know what the weather's like for you, but certainly here in Ottawa, it's a lovely sunny evening. So thank you so much for spending part of your evening with us. So this evening, what we're going to be looking at is we want to basically discuss, describe, and understand. So we want to discuss the priority setting in the new healthcare landscape. We want to describe wound bed preparation principles and the importance of barrier removal. So how do we navigate this new landscape we're looking at? And we really want to understand strategies to promote and support self-management, because that is really where this new landscape is headed. So, some of the things that we do know is that despite this advances in dressing technology and best practices, we are still in crisis. We're having increasing numbers of wounds with complications. And for the healthcare system, this is causing, havoc in terms of high dollars, greater antibiotic use, and we have a lot of challenges. And this was pre-COVID. And now with COVID, this has added really another dynamic to an already extremely stressed system. So how are we as clinicians supposed to navigate this kind of system? And how do we get our patients engaged? And how do we maximize wound healing? So, we have to really take a step back and look at the impact of COVID-19 on wound care specialists, because it's really, Karen's going to talk a bit more about this with some cases in a little bit, but certainly, Karen and I have talked, and it's been a real challenge for us as wound care specialists. We've watched our colleagues be redeployed, as wound care specialists into other healthcare streams. So, we hear countless stories of the hospital's wound care specialist being redeployed, given a 48-hour period to be up and running as an ICU nurse or an emergency department nurse, for example. So there's this huge need to upskill registered and non-registered staff in wound care as we lose the experts, in the field. And then we also need to look at educating and supporting the patients and families as we're asking them for this self-care. And many patients are fearful of letting others into their home or going out. So we really have to support them in this self-care. And this kind of brings us to what the third wave is. And the third wave is individuals with multiple comorbidities that are fearful of exposure to COVID-19, and they're avoiding seeking medical attention. So until they reach that point of crisis, and then they'll show up in the emergency departments in a point of crisis. And the picture you're looking at right now on your screen is someone that I just saw through telehealth that was refusing to leave their home and did allow the family doctor to do a home visit. But as you can see here, this is an individual with neuropathy. They had developed a blister on the bottom of their foot and a callus that then became very complex. And now at the point where they are in crisis. So how do we navigate this? How do we get people to trust us, to seek medical attention when they need to? And how can we teach them self-management when we can't have access to them? So if we look at some of the trends that we're seeing during the pandemic, is first we see that patients who are suffering from chronic wounds, we know they're in a uniquely dangerous situation during this COVID crisis because of this lack of access. Most wound care clinics are closed or working at diminished capacity, which becomes a huge issue. We know that there's a lot of new policies aimed at diverting resources to COVID-19 treatment. So they've left to the shutdown of outpatient resources and limitations in home care services. And we anecdotally hear stories of nurses trying to make the decision, well, I have to see so many patients, I don't have the time to go in to see everybody, and I can't teach anybody in the home how to apply compression, so we're going to stop compression therapy. And then the wounds are getting worse. And then finally to a point where the patient feels they have no choice, and then they go to the emergency department where once again, they don't have access to a wound care specialist. So, we see that with no access to training or professional monitoring, that these patients are at risk for developing complications that will require emergency medicine, which actually gives them further risk of exposure to COVID-19. And as I've already said, many of these patients are very fearful of requiring nurses to come into their home or to going out to visit because of the fear of exposure. Many of my patients that I'm following virtually now many are elderly, many have multiple comorbidities, and rightly so, they're very fearful of contacting COVID-19. And as well, many of my patients actually reside in long-term care, where for obvious reasons, they try to limit the number of people coming into long-term care and limiting individuals that are going to visit more than one long-term care home. So we're trying to virtually manage the wounds in long-term care among a group of staff that are already so short and so terrified. So if we look at, what does this impact then on individuals who are living with a wound, and how do they manage that fear of contracting COVID-19 versus fear of their wounds deteriorating? And this is, you're looking at another picture of an individual who had a wound on the dorsal aspect of their foot. It was progressing nicely. However, their fear kept them inside, kept them away from their healthcare professionals, and attempted to do their own dressings. And the wound rapidly deteriorated to the point where it was worse than what it had started with. And then there's some unintended negative consequences of COVID-19. So we have non-healing wounds when left untreated and unmanaged can result in significant medical issues. We see infections, sepsis, limb amputation, and in some sad cases, even death. And we see that individuals with chronic wounds, they often have other chronic conditions. And we have to be cognizant that if they're ignoring their wounds, they're probably also really ignoring other medical conditions as well. So as healthcare professionals, we need to make sure that we're cognizant and we're treating the entire patient so that we're not just looking at their wound, that we're asking them when we do have access to them, what else can we do for you? How has your diabetes been? Are you monitoring your blood sugars, and how have they been? Are you taking your heart medication? How are you feeling? This is an extremely fragile cohort of patients that are at high risk for developing COVID-19. But, they're also that high risk for increased morbidity and mortality and loss of life or limb if their access to wound care is abruptly discontinued. And sadly, this is something that we're seeing frequently, that we are seeing that this abrupt cancellation of wound care so that they don't have access to their wound care specialists. So, here's another thing we need to look at. What happens if an individual with a chronic wound also has COVID-19? And, this is something that I started to percolate and think about. I thought, well, some of my patients have developed COVID-19 and some have needed to be hospitalized. So, and some are remaining in long-term care with the COVID-19. It's like, so what's happening with them? Well, I've talked to the patients and I've talked to some of the nurses, and what we find is that they're coming in with their skin integrity already compromised. And that because of their, having COVID-19 and the degree of illness that they're suffering, we know they're going to be at higher risk for additional skin breakdown. And that we also know that with critical illness, there's a heightened risk for pressure injuries, skin tears, moisture-associated skin damage, and medical adhesive-related skin injuries. So these patients are at heightened risk to developing new wounds, but also when someone's extremely critically ill, especially if they're admitted to ICU, and this is by no means to discredit our ICU colleagues, but their focus changes from skin health to one of life savings. So at times, the non-healing wound that someone may have on their foot will not be a priority if that individual is critically ill and needs to be in a prone position and they can't be repositioned to do the dressing care on a regular basis. So we have to be very cognizant that if someone has a chronic wound, that wound may not get the attention that we would like if they get into a critically ill state. But with anything, we have to realize that with challenge comes opportunities. So we need to look at what are the challenges and what are the opportunities and what barriers can we remove. So if we're looking at opportunities, well, we have a great opportunity to engage our patients and get them more involved in self-care. We have a whole host of virtual platforms that we're all becoming very comfortable with, whether we like it or not. And the other thing is that these redeployed staff are bringing back new knowledge and skills to the workplace. So some of my colleagues who've been redeployed to the critical care settings, what we're finding is that, they're reporting back that they're learning a lot in the ICU settings of wounds in critically ill patients, and they're teaching their colleagues in ICU how to prevent some of these wounds. And they're bringing back valuable information to the rest of us on some of the challenges that ICU nurses are faced with. And some of the, then we can strategize and come up with some ideas of how we can help our colleagues in ICU. We've also had to develop a lot of quick access training sessions, which has shown us that we can actually do some upskilling of information very quickly for healthcare professionals. But I think one of the things that's really been highlighted just by the number of consults we've all getting is the importance of healthcare professionals with advanced wound care and knowledge and skills. So people are really starting to realize the value of having this advanced knowledge. But when we look at the flip side of some of the challenges and barriers we face, we know that some patients and families just need a lot of support, especially when you're initiating self-care. So we have to make sure that we can't just throw the word self-care out there. We need to look at how are we going to get creative and support someone with self-care and figure out where are the barriers and how can we remove some of those barriers so that the individual can master self-care. And what I always struggle with, my research side of my practice struggles with, how are we going to capture outcome metrics in self-care patients? So as nurses, we always like to, see our wounds from start to finish and look at how can we look at the outcomes, how are the wounds healing? And that's more difficult to capture when you're looking at self-care. And we know that there is that reduction of access to specialty care, example, debridement. So that becomes very difficult. How do we remove those barriers? How do we have somebody have access to a nurse or a medical colleague who has the knowledge, skill, and judgment to be able to do debridement? And we have less opportunities for staff education and mentoring. We just don't have time to do the mentoring that we would like. So these are some of the challenges that we are faced with. And, you know, there is no easy answer, and we're certainly not going to solve these barriers this evening. But it's a challenge I would like you to think about and to look at your own practices and think, what can I do to overcome these barriers? So one of the important things that we have to look at is wound bed preparation, because that's where it all starts. So when we're looking at working with patients towards self-care, we have to frame it around how can we maintain proper wound bed preparation so that we can set this wound up for success in terms of healing rather than failure. So if we're looking at a definition of wound bed preparation, it's the management of a wound in order to accelerate endogenous healing or to facilitate the effectiveness of other therapeutic measures. So the reality is that we have to look at those barriers, and some of them we've already discussed, that affect the patient with the wound and not just the wound itself, to determine how are we going to heal this wound, what are we going to need to do to break down those local barriers to wound healing. And remembering that some of those are part of the system. So that access to debridement, we're certainly not going to be teaching our patients to debride wounds. So what do we need to consider when selecting our treatment path? And, you know, I love the TIME acronym. So, you know, it fits in very nicely in terms of what does a wound need, but we also have to remember, what do we need as clinicians? So we need to minimize infection, we need to do our wound bed preparation, ease of use, patient comfort, and healing time. So we need easy, affordable, and effective. But we have to remember that the center of all care is our patients' needs. So when it comes to patients, we have to remember that often their needs are very different from our needs. So when you talk to patients and when you read the literature around what patients want from wound healing, you find the mobility and comfort are high up on their list. And as you can see from the clinician's list, it's lower down on that list. So we have to think about our own list, and we have to readjust it so that we have to make sure our patients' needs are first. So mobility and comfort, then they do care about healing time. It is high up there on their list. They do not want to have a wound for a prolonged period of time. Pain is extremely important. They want to have pain-free dressing changes. And they want control over the wound, and they want to have a sense of security. And one thing that always strikes me is when patients come into the clinic and they know they're going to be seeing me, we pre-medicate them beforehand. We have them take medications before they come in. But certainly, you know, a lot of times the issue comes down to they're terrified of coming in to have their wounds changed because they're absolutely terrified of the pain that they may endure. So when we look at our wounds needs, from that perspective, we need to have a moist wound environment. We need to protect newly formed tissue. We need to protect from infection. And then we need to look at, can we remove the barriers to wound healing? So at this point, we're going to do a quick poll just to see where you're at with your wound healing. So the poll should be coming up any moment. So we'll just give you a moment to complete the poll. So we'll just wait for a few more people to vote, and then we'll look at the results. Okay, so when we look at our results, you can see that 75% said all of the above, and that would be correct. Certainly when we're looking at barriers to wound healing within the wound bed, we always have to remember biofilm, slough, exudate, and excess MMPs. So these are very important factors that we have to keep in mind in order for the wound to progress to healing. And unfortunately, you know, slough and exudate we can see with the naked eye. Biofilms and excess MMPs are not things that we can see with the naked eye. So this is where we have to use educated guesses and where we have to use our knowledge, add it to our skill and judgment to really try and figure out how we're going to remove those barriers. And I think if we can just take down the poll. There we go. So why is wound bed preparation so essential? Well, we've just given you some of the keys to that in our little poll. So we know that if we prepare our wound bed properly, we're going to control slough, necrotic tissue, microorganisms, biofilm, exudate, and those excessive MMPs. And the result will be we're going to have increased granulation tissue, we're going to have more oxygenation to the wound, and we're going to have positive bacteria, but we're not going to be, the bacteria is not going to overwhelm our host. And so these are very important that we really address these factors so that we're removing any of the barriers that we possibly can. But how? So we know that it's going to be solution driven, and we need to use the principles of wound bed preparation together with advanced therapies. So this is where the TIME acronym comes in. So we want to make sure that the dressings we choose are going to remove barriers to healing as much as possible. So they need to be very active dressings, they need to be versatile, responsive, and they really need to address all aspects of the TIME acronym. So if we, just to remind you of the TIME acronym, we have to look at the tissue. So address the non-viable tissue, because we know that's a huge barrier, right? Our cells cannot migrate to fill in that wound if there's necrotic debris in the wound. So this is where we need to look at debridement. And, debridement will be done based on the knowledge, skill, and judgment of the clinician who's primarily taking care of the wound, or in many cases right now, the patient. So I am not going to be having my patients do surgical or conservative sharp debridement on their wound. And, in many cases, a nurse may have the skill to do that, to do conservative sharp debridement, but it's not the right setting, right? You're not necessarily going to be doing debridement on many people, especially those on anticoagulants, in their home setting because of the risk of infection and bleeding and other complications. So we really need to look at that. How can we do debridement? So this is where we would be looking more towards the autolytic debridement to try and remove as much unviable tissue as we can until we can get the individual to a safe environment to have that wound either sharp surgical debridement or with conservative sharp debridement. Now I admit there are other forms of debridement such as mechanical, which is very painful, or we do have biologic. I personally am not a big fan of the maggot. I know they work really well, but the ick factor always gets to me. But I have worked a lot with larvae therapy. It's just not my favorite. And maybe later on, Karen can tell you a bit about that, but it's not my favorite. Mechanical, as I said, is very, very painful. So, we do have as well enzymatic debridement that we can look at as well. But once again, it gets a bit more complicated with patients. So really right now, we should probably be focusing on that autolytic debridement because that is something that we can teach patients to do at the bedside. We need to address infection. So we need to look for signs and symptoms of infection, either superficial infection or deep tissue infection. And we need to protect those at risk for infection. And part of that protection is moisture control and removing the non-viable tissue. So we need moisture control, the M and the time. We really need to remove excess moisture. We want to maintain moisture balance, but we want to make sure that the wound is not overly hydrated. And it's interesting when you really talk to patients, it's in the literature as well, but I find just talking to my patients and asking them, when do they have the most pain? And many of them will tell you that their pain gets to a heightened point when the dressing itself is saturated. And it's when the wound starts to become, edges start to become macerated, the patients will start to complain of excess pain. And then we have to look at that edge effect, which is the E in the time. So we need to protect those wound edges. We need to look at that microclimate. What is happening with the skin around the wound? How can we protect that skin? And how can we help propel the wound towards closure? So, these are some very important variables that we need to think about as we're moving our patients towards self-healing and self-management, in how can we take this model and teach it to our patients in a way that they can understand? So if we look at some of the lessons learned that we've had, well, we know that, sadly, wound care specialists are being diverted and other nurses are having to fill in on wound care. Some have a keen interest and have really picked up the knowledge very quickly. And I can tell you from the number of applications we've had to both the wound ostomy and continence education program, or the NSWAC program, and to our SWAN program for RPNs and LPNs, the Skin Wellness Associate Nurse program, that our applications have actually increased since COVID-19 started. And a lot of it, when we've been polling our applicants, is that we're seeing that many nurses are starting to get exposure to wound care where they didn't before, and it's whetting their appetite and they want to learn more. We know that those living with wounds are at a crossroad between the fear of getting COVID-19 and wound deterioration, and that the consequences for that lack of care is an all-time high, and that we need to be there to support them through this, and we have to understand and acknowledge their fears. We need to understand that the basics of wound bed preparation is going to help remind those to check in with the wound's needs. And it's a concept that we can use to teach our patients how to use products effectively. And most importantly, we need to identify and remove barriers, as a way to, how can we jumpstart the healing process, and how can we remove barriers, and how can we help our patients at this point in time to remove their own barriers. So I hope I've given you a bit of an overview of some of the issues that we're dealing with in healthcare today, and some of the issues our patients are dealing with. And now I would like to invite Karen to come on, because she's done some great case studies that I think will be very interesting. Karen, you need to unmute yourself.
Hi, everyone. Sorry, I always forget about unmuting myself. Okay. And for some reason, there we go. I hope everybody can see my slides okay.
Yep, they're great.
Awesome, super. All right, now I just want to put that down and put that away there. Okay, all right. Kim did a great job on presenting our current reality with our most vulnerable patients. And really the focus today is really on those patients that have healable wounds or maintenance wounds. And, I'm going to bring it down to something that's a bit more local, so that we can really look at options for dressings to help you navigate and remove the barriers and really add to your arsenal or toolkit to be able to provide your patients with the best care given our current reality. So I'm going to talk about a product called Drawtex. And I don't know if most of you can see this, but it's a really cool product. It feels like felt. Nice smooth smell. Anyway, it's a nice product. It's smooth, it's simple, it's very flexible. And it has, it's an active dressing. And what I like about Drawtex, I've used it for a number of years, and and whenever we were able to have it on our formulary, it became our go-to dressing because of its versatility, its ability to really deal and manage unpredictable wounds. And so I'm going to step back and explain the mechanisms of action, how this product works. It actually has 3 mechanisms that are occurring all at the same time. And the first one is capillary action. The dressing is made up of a cotton viscose derived from bamboo. And if you remember about bamboo, it's a very thirsty plant, and it's always seeking moisture. So hang on to that thought for a second. The product is actually punched with, has little microneedle holes in here that actually act as capillaries to help draw the fluid in and lock it into place. So it has very good vertical wicking. It's similar to my favorite paper towel, Bounty, the heavy duty picker-upper. Not only can it be used for heavy spills, but it can be used for any spill. So again, for any type of, any patient with any exudate, it's a good option for. We'll talk about that more in a few moments. The next mechanism of action taking place at the same time is, as you can see in the middle here, what's called hydroconductive action. And this hydroconductive action is actually pulling fluid vertically and also horizontally at the same time. It's based on the physics law, Darcy's law. Just remember Mr. Darcy from Pride and Prejudice, but anyway, it's not him, it's actually a physics law. But the principle describes how trees actually get their moisture. So the roots pull moisture up vertically and then horizontally all the way out to the leaves, so that at any time the limbs and the leaves are getting the moisture they deserve. So it's basically seeking out moisture all the time. And that's the main ingredient, like as I mentioned about bamboo, because that's what bamboo is always doing. It's always searching for more moisture. It provides amazing fluid management properties that are unique to Drawtex versus any other kind of absorbent dressing. And at the same time it's happening, there's the electrostatic action that the polarity changes and ends up drawing bacteria and other positively charged, negatively charged particles into the dressing. So once the dressing is moist, the polarity changes, and as I mentioned, it pulls bacteria and locks them into the dressing. Christine Moffat completed an in vivo study showing that Drawtex actively moves bacteria not only from the surface of the wound, but from the wound tissue, so that by removing that bacteria, we're removing inflammatory response and also pro-inflammatory elements such as MMPs that would decrease the wound healing and wound closure. By not having them there, it helps to increase angiogenesis and, of course, fibroblastic activity. So when we speak on this, what makes Drawtex really different is the activity, those three mechanisms of action that are taking place all at the same time. So this slide here, I'm just going to pull this all together to show you, is that, you know, when you take a piece of Drawtex like this and you put some fluid into it, as soon as you put the drop in, you'll see here this picture on my left, your right. You can see how the blue liquid is actually starting to spread horizontally in this strip of Drawtex. By adding another strip, you can see that it's starting to seek out the fluid. Actually, the product is drawing fluid, the moisture, to the dry areas. And as you continue to add more layers to it, it continues to draw the fluid. So again, what you're seeing is that there's constant movement of the fluid within the dressing. It does not leak out through or seep back into the wound, which is really fantastic because this product can actually absorb like that really thin exudate, but also really that khaki stuff, that really tenacious stuff that ends up unfortunately pooling in the wound base because it's so thick. But Drawtex does an amazing job of pulling that up. This last picture here shows the vertical and also horizontal pull of the dressing. So you can actually layer, you can provide layers of the product on the wound bed, and you'll see this in a minute when I show you our case study, because it just continues to draw the fluid up through all of the layers, again, constantly managing that exudate. It makes sure that there's no retrograde fluid, and again, it locks it in place. The Drawtex, because it's actively working, it's the blue collar of dressings in the most positive way, because it's always active, working, and really just doing a really powerhouse job on a regular basis. Kim talked about the principles of time and what we need to do to remove barriers to wound healing. And what you can see here is these 5 elements of facilitating wound bed preparation are accomplished using Drawtex. The first thing we've talked about is around the exudate. And as you can see here, Drawtex has the ability to draw up to 150 mils of exudate or fluid per hour. And this has been verified by studies. And the wound fluid management is really, as Kim mentioned, is absolutely critical, because if you have too wet a wound, we're actually causing maceration, we're damaging the wound edges, we're allowing biofilm formation. It just gets really messy, and there's no way that you can have healthy tissue when you're basically drowning new cells. The next one is with regards to biofilm. It actually helps to decrease biofilm formation because it removes those those pillars that are required for biofilm formation. The moisture, so Drawtex removes that. The nutrients that are in the exudate, those get removed as well. And also the bacteria. You can't form a colony if you don't have a lot of buddies. So if the bacteria aren't there, it's very difficult to form biofilm. So that activity helps to really decrease that formation. And the other thing, of course, is that whatever is in the exudate gets drawn up into the dressing, which is, of course, any of your pro-inflammatory enzymes or elements like your MMPs. So those would get drawn up as well. The other thing that is amazing that we identified in our practice is that, and also has been demonstrated over and over again, is Drawtex's ability to debride slough and eschar. So again, it assists in debridement. As Kim mentioned earlier, this is one of the critical pieces that is being missed or noticeably absent during this time because patients don't have access to wound specialists who are able to provide conservative, sharp, or active wound debridement, sharp wound debridement. So using Drawtex helps you to basically, as it shows here, can been demonstrated to remove up to 77% of slough and eschar over a 3-week period. Now, it sounds like this is it sounds like an amazing dressing. And of course, I am biased. It is because I've used it a lot. I want to share with you the success we had with a patient who had inflammatory ulcers over a 10-year period. So this is similar to the patients that Kim was talking about. So this person had an autoimmune disorder, was being treated with biologics, was not maggots. I don't like them either. But biologics, was on steroids and a lot of, basically all kinds of medication that we know reduces wound healing. And so we saw this patient came for about 8 months that we've been seeing them, and we're trying everything and nothing was working. The wounds were very painful. The exudate was to the point where their shoes would be completely soaked each and every time they came in. They were being seen every other day because they refused to come daily. They probably could have needed dressing changes at least daily, if not more often. They were getting 4-layer compression, and we were just barely managing. So you can see the degree of slough, the paleness of the wound, the swelling of the wound edges, and so we decided to try Drawtex. Now, we really weren't sure what Drawtex was going to do, and so we dressed the wound like we had been doing before. So we dressed the wound using applying it circumventionally. I should mention that, sorry, I'm just going to go back. This is actually one leg, and it's a circumventional wound. They had it on both legs, and this was the worst leg. So you can see here that we used a lot of layers of Drawtex, circumventional. We kind of did overkill. Don't do what we did. We now know that you don't need to do all of that stuff. But layering did help significantly. If you can see here that the maceration that we were seeing on a regular basis, there's a little bit of maceration at the heel. This is after the first dressing change. So, and you can see the tenacity of this exudate that is being drawn up by the Drawtex. So after 1 week, you can see a change in how the slough is being removed from the dressing. The patient had significant pain at dressing changes, actually when we applied the dressing and when we would remove it. And so because we weren't sure what it was going to do, we would soak the Drawtex with saline before removing it. We continued to use the Drawtex because the patient was absolutely thrilled to see this change, that finally their shoes were dry for the first time. And so we applied a vertical application. So 3 weeks later, this is what we're seeing here. And you can see that we're starting to see actual granulation tissue. We're seeing the wound base for the first time in a long time. Whoops, sorry, little touchy there. The wound edges are flattened, a little bit macerated because we were using the product and again applying it way over the edges. But nonetheless, we can see there's a significant change. The pain had reduced 3 points. The odor that was there was significantly, basically was gone. And we were able to move this person from a 4-layer compression to a 2-layer compression, and reduced, of course, the size of the dressings, because by week 3 we only required 1 layer of the Drawtex to manage the exudate. And the person was ecstatic because finally they could put on regular shoes. So all of those things, again, a case study to demonstrate the efficacy of Drawtex on really what we would, we would have classified this as one of our world's worst wounds, because it was a real challenge for us. The other positive note was that there was a movement towards healing, and for the first time we had a 2mm size wound surface area reduction. So after 8 months, this was the first time we had any significant change in the wound surface area. So you can see that Drawtex here removed a number of barriers, the exudate for sure, the malodorous exudate, a reduction of pain, and of course you can see the debridement, the removal of the slough was just absolutely, we were quite surprised by how well the Drawtex worked on this. So that's one product that you can use in your arsenal. The benefit of that is that Drawtex is that it's so simple to use that patients can easily, like, again, you can use this on, this is their edema roll, and you can use this for your really, those really leaky lipidemic patients who have that malodorous leakage. This works really well under compression. For your diabetic foot ulcers, you can put this on the foot. Works really well under any kind of pressure in a total contact cast. Again, like, it's just really cut and kit. You can do something like, this, so that you can fit it on the elbow and then just apply a secondary dressing. So the flexibility and the ease is absolutely amazing. It's patients don't have to think about how to put it on. It's just like basically putting on gauze, only it's significantly better. So those are some options as far as how Drawtex can be used. And because of that flexibility, it's a really, really good option for a number of your patients. The next product we want to talk to you about is URGO Silver. In your care setting, there's going to be situations where you have challenging wounds, like the one I showed you, that where you may feel the need to apply an antimicrobial on the wound base. Well, Drawtex does capture and lock in the bacteria. Depending upon what's going on with the patient, you may need a wound interface that has silver. And of course, as most Canadians, we usually go to silver first because we like that. But URGO Silver has been demonstrated to work well with Drawtex. And so, we have basically 2 active dressings that we can choose from and that we can use together. So I'm going to explain about URGO. I'll just put all of this together. URGO Silver has URGO as its base. The base, actually, one of the main ingredients is the carboxymethylcellulose that we are familiar with our ostomy barriers, our hydrocolloids. And when the LIPIDO-COLLOID technology, actually that's on the product, which is looks like this, which is absolutely lovely. When it warms to room temperature or comes in contact with the wound base, it actually forms a gel. And that gel provides an ambient moisture environment for the wound base. So, it's not actively providing moisture like you would with a hydrogel, but what it's doing is it's helping to provide an atraumatic interface for the wound. It slowly releases the LIPIDO-COLLOID gel over time, as well as slowly releases the silver sulfate in the dressing. And this holds its integrity for up to 7 days. What I really like about this product, of course, as you can see, it's very flexible. When you feel it, it feels kind of sticky, but there's absolutely nothing on my hands, which is great when you're working with gloves. It's great for the patients because, again, it's really difficult if it sticks on itself, then patients are going to get frustrated. So this makes it really easy for them to apply. The other thing about the LIPIDO-COLLOID gel is that, again, as I mentioned, it provides that ambient moisture so that it's hydrophilic, so it's holding and retaining moisture over time. So if you're concerned about the wound getting dry, using something like URGO or URGO Silver helps you to reduce that concern. When we know that we're at a place where we're not able to see our patients as often as we need to, when we have unpredictable wounds, having something that we know can manage that unpredictability is really beneficial. So how do we know that that works? Well, there's been studies that have demonstrated the benefit of the lipocolloid gel is that it actually, if you see here this this graph here on my left, your right, the lipocolloid gel, TLC, as you can see here, actually facilitates fibroblastic collagen and hyaluronic acid formation. There was after 2 days, having the URGO tool on the wound bed actually helped to facilitate fibroblastic activity by 70%, whereas you can see the other interfaces actually inhibited fibroblastic growth because they were not active. Anything that we use on the wound for every step of wound healing, it needs to be doing something. It needs to be active. Otherwise, what we're doing is that we can actually, there's a risk that it will interfere with wound healing, as we've shown here, which is something that we don't want to have happen. The graph in the middle shows how the URGO tool maintains its integrity. And so you're going, okay, well, why do we need that? Well, the integrity of the dressing is that you know that this product here is actually going to what's on this interface, on this interface, is actually going to stay there without drying out, or without basically falling apart. If it falls apart, then it's not doing its job, which means that the wound is at risk for trauma. And don't forget, when we're looking at new cell growth, that tissue is very vulnerable to damage or to injury. So we want to make sure that we protect it. The other thing to think about is that you want something that actually is going to allow the exudate to pass through. The pores on URGO tool have been designed to allow exudate to pass through. At the same time, make sure that the tissue does not grow into the pores. So that's a really important thing to consider. The other thing that I want to just remind you of is that when we're looking at using a petroleum or petrolatum-based interface, if you have a lot of exudate and their pores get clogged, or the pores are not of a sufficient size to allow exudate to get through, it'll pool underneath the dressing and cause peri-wound maceration, can cause peri-wound irritation, wound edge damage, and of course then inhibit cell growth. So those are things that you want to be considering. The other thing in this picture on my right, your left, demonstrates that by having an interface that actually protects or is atraumatic to the new tissue, the granulation tissue, we're not going to cause trauma. Kim mentioned about mechanical debridement, which is, of course, wet to dry saline gauze dressings. We have to consider that some of the wound interfaces, if they've lost their integrity, will be similar to basically a dry gauze when we remove it, and will cause damage and actually can further inhibit cellular and wound healing. So those are things that we want to be thinking about. So those are reasons why the lipocolloid, there is a difference, because this product works very well in conjunction with the gel that stays for up to 7 days, the slow release of silver. So when we think about the silver, probably you're similar to my thinking, is that, the key question has always been, how much silver is in the dressing? How do I know that this dressing is actually going to do what it says it's going to do? And we want to have the confidence that when we're using a product that is an antimicrobial, we want it to do the job. And especially at this time and moving into the third wave, we need to have confidence that the products that we're using will actually help towards wound healing, will help to manage exudate, will help to manage bioburden for those maintenance wounds. And you can see here that URGO did a randomized controlled trial to show the clinical efficacy of a silver dressing compared to a neutral dressing. So what they did is 102 patients were randomly assigned either URGO tool without silver or URGO tool with silver for 4 weeks. And then they followed up with another 4 weeks with URGO tool neutral. The result, as you can see here, right at day 1, you can see that the signs and symptoms of infection started to decrease. This green line here is the URGO tool with silver. And you can see that the signs and symptoms of infection started to drop down. And by 8 weeks, there was a 48% reduction in wound surface area. You can see that the wound progression started immediately. and then continues. So what we're showing here is that this product does what it says it's going to do. The silver, the amount of silver in the dressing is a slow release. It also provides you with the confidence that the silver is going to be effective in reducing the bioburden on the wound surface area. So I've presented with you today. We've talked about 2 powerful dressings that actively support wound healing and that help to remove the barriers that we've been discussing, that help to support and facilitate wound bed preparation along and addresses all of the aspects of time. The options for care during the time to your 3rd wave really need to be able to help you support your need for a better solution for your patient and for you. And when we think about how patients who are having to manage their own wounds, we want it to be easy and economical, and just like literally just a no-brainer. This is what I need to put on. So we want our challenge really is that we can't predict what's going to happen to the wound. What we can do is try to address as many barriers as possible and choose dressings that will actively help to support wound healing and wound closure. If there is a concern about using Drawtex sticking to the wound, and that can be a risk, then using URGO tool as a wound interface will help to address any concerns about any kind of sticking or disruption of the wound base. In our experience, we've really not experienced that, but that's always an option for you. So as I mentioned, together, these products address time and will provide confidence that you need for your challenging wounds, for your patient's wounds, and also for you in the future. So now we're going to move to questions. Do we have any?
Yeah, so thank you so much, Karen. You've certainly provided me with a lot of questions that are coming up in my mind, but I will be nice and I will ask the questions. We had quite a few questions come in. And while we're doing the question and answer, anybody who's listening, if you're thinking about any questions, please feel free to put them into the question and answer, and I will gladly, we'll bring them into the conversation. So one of the first questions that we had was, I think I'll take this first one, Karen. Okay. It's around doing telehealth visits and, asking, are there any advice for doing good wound bed preparation via telehealth? And, this is something I think we can both speak to very readily, is that, telehealth is always a challenge. And one of the first things I always tell people is make sure that you have the best platform possible so that you can, try to do it by video if you can. Make sure that you've got the right secured environment as well. We have to remember patient privacy. Don't be sending pictures by text or via email unless it's a secured email. So we really should be doing a secure site. I do a lot of video telehealth, and what I use it as a great opportunity to teach not only the nurse who's at the other end, but as well the patient. So, sometimes, it is just the patient. But I find that we can really use telemedicine as an education platform. What do you think, Karen? Is that what you do as well?
Oh, absolutely. There was a couple of consults that I had. They were way up in the rural north somewhere, and I used telehealth to walk the patient's family on how to do the dressing. So we had the dressings delivered, they opened up the box, and I'm walking them through step by step how to do the dressing. And then the next dressing change, we again used telehealth to make sure that they were doing it right. And it was almost like this, this family was just overjoyed to be able to provide this care for their parent. And also this, you could just see this confidence building that, oh my gosh, I can do this. This is really cool, right? But again, it was making, being able to be very clear and simple in the instructions, choosing dressings that were easy for them to be able to use.
Yeah, I think that's, one of the keys, and, making sure that you've got your technology all set up. And as any of you listening this evening, you can tell that my technology has failed me because my Mac computer would not speak with the web platform. And so that's why you get to see Karen and not me this evening.
Good to see me, yes. Yeah. Yes.
They're so lucky I still have COVID hair, so they're very lucky. So some of
I
the
do
other
too, but
questions,
very strategic. So there you go.
yeah,
Okay.
exactly. We've got a lot of really great questions that that have come in. And, one of which is I'm going to take again because it says, how does Ergo Tool work for skin tears? And I've done a lot of, anybody who knows me knows that I love my skin tears. And, we've done a lot of work using Ergo Tool with skin tears. And I invite anybody to go to the NSWOCC website because, I'm a little bit proud, but our poster on using a non-contact layer, which happened to be Ergo Tool for skin tears, actually won the best poster at our virtual conference. So I invite people to go in and look at that because, Ergo Tool is one of those things that works very, very well for skin tears. But moving away from skin tears, I'll get off my rant for the evening. But there's some great questions here that I think will directly relate to you, Karen, is, questions around how do you use Drawtex for packing? And do you have to cut it? Does it come in different shapes and sizes?
Oh, good question. So when we first started using Drawtex, we cut our own, we made our own packing. And we all know that it's a real challenge to find something that can go into a tunnel and maintain its integrity. And so Drawtex does that. So this is already cut to size, which works really well. One thing that Drawtex, we've not, in my experience, it does not swell, right? So it stays the same, which is quite interesting how it does that. It works really well. We used it on somebody who had a lymph channel fistula post removal of pins and plate. And we used this, we just gently packed it into the hole and then we layered the Drawtex and we were able to finally get that fistula closed. But the challenge for this person was that they were changing their dressing every hour. And so we've had really good success using this in tunnels and sinuses. And it's really good for fistula management as well.
Yeah, no, it certainly is.
Yeah.
It's certainly one of these products that is very versatile. And, I know that this evening is sponsored by Ergo, but I think that, no matter what, you and I would be having the same conversation about how versatile the product is. And, some of the questions come around, does it need a secondary dressing? And that depends, right? I use Drawtex a lot, especially the ribbon, for people with pinital sinuses, and the person can change it themselves. Yeah. It wicks it away. I've used it for ITD. Have you used that under breasts and in groin? I find it wicks that moisture right away. Have you tried that?
No, I haven't. I haven't done that. That's a really good option. I've not considered that.
So the patients who unfortunately have the big abdominal pannus and they get ITD under that pannus, and Drawtex is such that an affordable alternative to some of the other textiles that are out there that you can put underneath that pannus, and it just wicks that fluid right away. So that's something.
So you've got the edema roll, which is really good, right? So this is So this would make it very manageable for patients for sure.
And it's so comfortable as well. It's so soft. So we're going to take one more question because we're just at 8 o'clock. So and I think that this is there were two quick questions. One I think is how do you become a telehealth wound nurse? And from my experience is you have to find the regions, who's doing it in your region, and go with your credentials and just keep banging on the door. If you live in Ottawa, it's a little bit trickier because there's a lot of people doing it. In the Toronto area, how are things there for telehealth? A lot of people are doing it, are they not?
They are, yes.
I know that out west in the hospitals, the wound care specialists in the hospitals are really working in collaboration. So I would say go wherever you are in Canada, go to your health authority, find out where the telehealth is happening and volunteer to get involved. And the last question we're going to go with is, and this is an Ontario question, but will these products be on the Minister of Health LINS formulary? And I don't know I know it depends on where they are, right?
Exactly, and it's the ongoing struggle. So again, like what I'm just going to echo what Kim said earlier, is I know that there's each LIN or now region, they don't want to be called a region, are very particular on how they bring in new products. Being able to go with a proposal to say, using this product, this, and this, we would be able to support patients, we'd be able to reduce nursing visits, we'd be able to support. So we've given you a lot of ammunition with regards to how you could make a case to say, let us do this, even if we could use one patient population, to be able to demonstrate how effective this product is, and how it could be overall save money to the system and really provide patients with confidence and reduce the deterioration of their wounds would be huge. And so again, going and knocking on doors, find out from your superiors or your director who you would be able to speak to, and I'm sure that your local URGO representative would be able to support you in providing the information you need in order to be able to provide that information to your powers that be. You have to you just have to keep knocking on the doors and being like, it really, that old saying that the greasy wheel gets the grease. The squeaky wheel gets the grease.
Yeah, exactly. Yeah. My approach is normally to flood their inboxes with requests, and eventually they'll give me what I want just to shut me up.
Yeah, there you go.
So with this, we are out of time, so we're going to have to end our session tonight. So on behalf of Karen and myself, I would really like to thank URGO Tool for inviting us to come speak with you this evening. And I think we'll hand this back over to the organizers now.
Thank you, everyone.
Wonderful. Well, thank you, Kim and Karen, for your engaging talk. And we'd really like to thank everyone else for attending this webinar, Time for a New Path Toward Healing, Advancing Active Wound Bed Preparation. And if you have any other questions, please contact Wounds Canada at info@woundscanada.ca. Again, it's info@woundscanada.ca. Once you leave the session, a survey will pop up, and we'd really appreciate if you would complete that survey and provide us with your valuable feedback. You have the opportunity to sign up for future updates from URGO Medical and to receive a starter pack with the products presented today. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of this webinar. So on behalf of our presenters, URGO Medical and Wounds Canada, thank you for joining us today. Have a great rest of your day or evening.